Welcome back. If you're joining us, you're watching Channel 1 News Hour, and it's now time for us to focus our discussion on your health. And specifically, we will be looking at the progress that we have made so far as a country in tackling HIV and AIDS. And now joining me in studio is the program manager at NASCOP, that is Dr. Joyce Wamwicwe, who will be giving us more insight on what really is happening and what are we doing as a country to try and eradicate HIV and AIDS and ensure a majority of those who are living with HIV and AIDS access treatment. Thank you very much, Dr. for coming to our studios.
Asante.
Let's talk about the progress so far. Where are we as a country when we talk about HIV and AIDS? How many people can access treatment?
Okay, so first and foremost, thank you to KBC for having us. And currently the statistics are we have about 1.5 million people living with HIV in the country, and about 1.2 million are on ART, antiretroviral therapy, and 83% of those are virally suppressed. We've been able to identify about 78% of the 1.5 million because it takes a HIV test for you then to follow on the cascade of being put on treatment and us monitoring your viral load. Yes.
There was a time you were concerned that a majority of Kenyans were not getting tested. What is the status now? Are we now becoming more encouraged to get tested?
Yes, of course, things have changed over time. Kenyans are more open to testing. But of course, we see certain groups of people who are still shy or resistant or do not want or do not think they need to take a test. Specifically, we are talking about men. So when we look at the statistics, in terms of identification, about 64% of the men living with HIV, we have been able to identify them compared to 76% females. So you can see the disparities.
Just go to you.
And then, and also young people. We are now, a lot of new HIV infections are among that subpopulation. So we are encouraging young people also to come out and get tested.
Why do you think, perhaps from your statistics, why is it that men are shy to get this test in the first place?
Okay, it's multifactorial. It's many things. So one, men like things that they can anticipate. They like to know that if a facility opens at 8 a.m., they don't want to be kept in the queue. I mean, to be kept outside the gate waiting with people coming in and opening the facility at 8:30 a.m. Men are predictable. They like predictability. So if a facility doesn't open on time, they don't have time. Then we know our men, a lot of them work long hours. And one of the things we are really encouraging the facilities is to have men-friendly kind of services. So if men say they're available on a Saturday, make sure that there is the facilities open for testing on a Saturday. The other thing is the opportunities for testing are quite limited when it comes to men. For women, we are always getting tested. We are always getting into contact with the healthcare system. When we are pregnant, we go for the antenatal clinic. When we have the small children, we are taking them for immunization. Plus also women do not stay with a problem for a long time. If you have a headache, you find yourself seeking some sort of medical attention. But for men, you know, the whole idea of I have a headache, I have to go to the hospital, it's seen to be,
they're actually going to
I
the
am
hospital,
weak.
It's a crisis.
So we find even if when we look at people living with HIV accessing care for the first time, we usually use CD4 to measure the immune status. So we find compared to women, men come at a pretty low CD4, meaning their immune status is really, really low. And they come with opportunistic infections like tuberculosis. Yes.
So that's why it's a challenge for you.
Exactly.
All right, let's talk about, the HIV survey. Tell us a little bit about that.
So we For the last couple of years, we've been having the national wide survey, and the first one was in 2007, the other one was in 2012. So we now have the third round. And for this year specifically, it is called KENFIA. The previous ones were called KAIS, Kenya AIDS Indicator Service. Yes. But now we are calling it Kenya Population-Based HIV Impact Assessment, because really we are seeking to look at, we've been managing HIV in this country for about 3 decades now. We have a lot of donor support. The government also has put in quite a lot of resources. So what's the impact of all that? Have we managed to reduce the new HIV infections? Are the people who are HIV positive and on treatment, are we able to put the virus to a very minimum level? And then for the first time since devolution, we will be able to give counties their statistics on, where are they when it comes to burden? How many people are living with HIV in counties? And are people accessing care? In line with universal health care, we want to know, if I want to take a HIV test, say in Garissa or in Kwale, have people been able to access that particular service? And then when you go for antenatal care clinic, for example, HIV test is one of the profiles that we do. Is it being offered to every woman who's accessing any healthcare facility in this country? So we'll be able to measure our coverage of services. We'll be able to measure the reach also. We hope to identify places that have not been reached by the services and also subpopulations.
So how many people are you targeting to capture under this survey?
So the survey is, we are hoping to visit 800 clusters. That is about 20,000 households. They have been randomly picked with the help of Kenya National Bureau of Statistics. They are not picked on the basis that we know that there is a HIV person or who's infected person who's residing in that household. We randomize, working together with the Bureau. We randomize so that we are able to get statistics that are representative of all Kenyans. Yes.
So is it a door-to-door kind of statistics, like you'll be going to the houses, and what is it in terms of security that perhaps they should know to how the people who come to do the survey look like and those kind of things?
Okay, that's a very good question. So for a long time it's been called door-to-door, but it's really not door-to-door. It's more of, it's a household-based survey. So in the clusters that we have selected, we are visiting 25 households. So it's not necessarily serially like one door to the next door, but it could be one door and then the 5th door, but within the cluster that has been randomly selected. So the KENFIA survey staff are really like, they have the KENFIA uniform, they have the KENFIA name tags. And I understand from the counties that we have already gone to, you can already tell when KENFIA gets to your county. There's a lot of mobilization on the ground. The survey staff are well trained. They know how to approach the households. But also we are working with the chiefs and the village elders at the grassroots to approach the houses. We are not just getting there. Together with the Bureau, the KNBS staff that's at the county level. Yes.
Perhaps you can paint for us a picture. When you get to my door, what is it that I should expect? Are you going to test me? Is there a procedure, perhaps counseling before the testing, or what really happens once you're inside my house?
Okay. So let's start with before I even get to your door. Ideally, before I get to your door, you should have heard about KENFIA, because a few weeks prior to when we get to the cluster, we are having intensive mobilization, not just to the households that have been sampled, but in that general area. So we are having a lot of mobilization activities, working together with the grassroots, the chiefs and the elders. Then once we get to your door, we of course request to speak to the head of the household so that we are able to explain why we are there. So we give the objectives of the survey in a very simplistic manner, such that they are able to understand.
Yes.
And then we seek consent to be able to continue with administering the questionnaire, because we have a questionnaire that's on an electronic tool. So once the head of household says yes, then we are able to carry on. If the head of household says no, we request to understand why have you said no. So if it's about I don't have time, we request the head of household, then kindly let us know when you're available. So we are very flexible in that if you say you're available at 8 p.m., our service staff are there. If you say 6 a.m., there are people who are saying I'm available at 6 a.m. before I leave for work. We are available. So once we are done with the questionnaire, and at any point in time, we really indicate to you that at any point in time, if you're uneasy with the kind of things that we're doing, the questions, you are free to say no.
Yes.
Then comes in the blood draw, and we again seek consent to get to do a blood draw. And then before we do the HIV test, we now go through the protocols that are there and for HIV testing services in this country. So we do pre-counseling, and then we do the test together, not in a corner. We do the test together, and then there is post-test counseling, depending on the status, on the test result. Yes.
So in the event someone turns positive, do you do a referral, or what happens?
Exactly.
Or do you just count them as a status?
No. Our first thing is human beings first. We are very human being centric. And linkage is what we do. We're working together with the county health department. So once you are positive, you are taken through post-test counseling, and then you are handed over to the county, the sub-county AIDS and STI coordinator, who then, and of course you'll have said your preferred facility that you would like to go to be seeking care. So a referral note is given to you, and also a copy is taken to the county health department, and then there is follow-up and also supportive measures to ensure that you are linked to care in a very professional way.
But that is only if you're receptive. In the event you find perhaps a person who doesn't want to go through all these steps, what next?
Of course, it's natural. We say that getting to know that you're HIV infected is not a small thing, and we definitely understand that it takes a lot for a lot of people to accept that they are positive. So we do have a lot of mechanisms within the healthcare system. We have community health volunteers who have been trained to support the community when it comes to such things. And then depending, if it's even a pregnant woman, there are mentor mothers, and there are steps that we are taken, that people are taken through, not just because of the survey, but even at the healthcare facility.
Okay. For how long are you conducting this survey, and where have you been so far? How many counties perhaps have you gone through?
Yeah, so we've done the survey. We started the survey the last week of May, so technically the first week of June, and we've been doing it in waves. So the first wave was quite limited, and the counties that we have so far completed are Kisumu, Siaya, and Kwale. We are now in wave 2, going to finalize, and we are beginning to open up wave 3, and the waves are based on the laboratories, because we want to ensure that any blood sample that we get from the respondents, the integrity of the sample is maintained. So currently we have opened up quite a number of counties, about 17 counties, but we can approach a county like 3 times from different directions, given that we have a minimum, or rather an acceptable time from blood draw to the lab. So if it's more than, say, 4 hours, then we look at which other lab can this blood sample be taken, and so we approach it from that direction. So we can be to a county, like now we have just gone back to Mombasa, yet it was in wave 1. So we have gone back to Mombasa. And the reception on the ground is very good. People are very receptive, and it's also bringing up the need of people want to get tested. They want services at mashinani level. Yes.
So what is the the level of uptake of the self-test kits, which we've seen being advertised a lot, that now you can get yourself tested in your house? What is the uptake like?
Okay, we are still looking at data regarding that, but what we know is self-test kits are the next greatest, I mean, they're one of the greatest innovations when it comes to testing. And specifically, again, when we brought in self-test kits, we were targeting certain subpopulations. Again, we were targeting men who say they don't have time, they want to know in their privacy. We were targeting young people, because young people like hype. They like new stuff, but we were also targeting certain social classes, like the middle and the upper class. So the test kits are in the private chemists, but also we now are beginning to have the self-test kits in the public sector. But I can tell you, walk into any chemist, they're one of the hottest and fastest going commodities.
Okay.
Yes.
I'm informed our time is up, but I know you're currently having a conference, Turning the Tide.
Yes.
I just want to give you a moment to look into the camera and perhaps speak to the Kenyan peoples and tell us whether you feel the progress at which we are going as a country, we are going to be able to meet our targets and ensure all those people who are living with HIV and AIDS get treatment, and those who, and also the preventive measures that you have. Okay,
so that's a tricky question. So when we wake up every morning in the HIV program, we wake up to ensure that by 2020 we have met the 90-90-90 goals.
Yes.
And currently we are at 78, 99 and 83% of those goals. The good thing is we are always thinking through how do we get people to get tested, because once you get tested and know your status, the rest is kind of in a flow. So as we work towards getting the tests closer to the people, people also need to come out and know that it's good to know your status. Yes. It's good to be on top of things when it comes to your health, and health should never be a secondary thing. It should be your primary priority. But for you to get any help when it comes to HIV infection, the status, getting tested is the first bit. And of course, we do know it's voluntary. So we cannot force you. So I encourage Kenyans to get to know their status. And status for 2-3 years ago is not status today. As long as you know that you have been getting involved in behavior that could have resulted in you getting
that would put you at risk.
That would put you at risk, yes.
All right. Thank you very much, Dr. Of course, we are going to call you back to perhaps shed more light in terms of universal health care. How really can persons who are living with HIV be able to take advantage of this? That will be a discussion we'll have another day when we have more time. Well, that is Dr. Joyce Wamwicwe, who is the program manager at NASCOP, just putting into perspective what currently the government is doing, an ongoing survey for HIV and AIDS. And this time she's saying at least each county will be able to know the burden of HIV within the county. That way it will help in programming as the government focuses on the big four, one of them being health care. This is where we have to put a cap on your health, but Caroline Jenga is up next with the day's business.